tarde a todos. É uma honra abrir o segundo webinar do ciclo de videoconferências da Sociedade Portuguesa de Gastroenterologia, Hepatologia e Nutrição Pediátricas, no âmbito de um programa novo que é o Programa Educacional em Parceria com a Indústria, mas que tem a responsabilidade científica apenas da SPGP. Este programa tem como objetivo a formação continuada em gastroenterologia, patologia e nutrição pediátricas e está sobre a forma de webinars como este, bolsas e prémios. Como presidente da SPGP e em nome de toda a direção, dou as boas-vindas a todos e agradeço especialmente ao Dr. Warren Heyer, o nosso convidado de hoje, e ao Dr. Jorge Anil, o nosso moderador, assim como à indústria farmacêutica, nomeadamente à AbbVie, à Baxter, à Fresenius, à Nutricia, Pharmachem e Takeda. Thank you, Dr. Warren Heyer, for being here with us today, and I let you, Dr. Jorge Anil, introduce you.
Boa tarde a todos. É um enorme prazer ver esta vitalidade da nossa Sociedade Portuguesa de Gastroenterologia, Patologia e Nutrição Pediátrica, mesmo em tempos difíceis, e manter atividade científica com conferencistas de alto nível, como já tivemos uma sessão anteriormente, e hoje o tema essencial é doença inflamatória intestinal. I will now switch to English in order to introduce our speaker today. Dr. Warren Heyer is a pediatric gastroenterologist. He is, most of all, a very good friend. We were expecting to have him last year in our annual meeting. Unfortunately, due to the well-known circumstances, that was not possible. But as some people proposed themselves on live in camera before the cameras, I would like to invite him to come back to Portugal next November for our next presential meeting to talk about something else. But for today, the topic is what is new in pediatric IBD. Dr. Warren Heyer is a pediatric gastroenterologist. As I mentioned, he works at St. Mark's Hospital, which is a hospital specifically dedicated to digestive conditions, to IBD and digestive cancer. So he's quite a well-known expert in the field, and we look forward to listening to your talk. Thank you, Warren.
Hola, obrigado por vir esta noite. Thank you all for having me, to Professor Amil Diaz and Professor Piedade. So it's Friday night. I know it's difficult to get anywhere on Friday night, so I expect you to have your little bottle of Porto and you sit down and we're going to have a discussion for about half an hour. So this is my hospital. It's St. Mark's Hospital. It's based in North London. And we have about 3,500 patients with inflammatory bowel disease. And I look after the pediatric cohort, which is about 1 or 2 new inflammatory bowel disease patients per year. We have a big nurse-led service, and one of our biggest assets at St. Mark's is we have very responsive endoscopy. So we have been doing sedation endoscopy in children over the age of 12, a colonoscopy without anaesthetist really readily within 12, 24 hours of coming to hospital. And this has given us a really good responsive opportunity to gauge people's inflammatory bowel disease. St. Mark's Hospital is the national gut hospital in the UK. So tonight, this is what we're going to cover. We're going to cover 8 different objectives, and we're going to do it easily within the 40 minutes. We're going to look at changing the way we see patients when they arrive, how we can keep them in remission, what the impact of COVID has been, what's coming next, and never to forget both surgery and never to forget cancer. So when I started and when Jorge Diaz was in London, this was the sort of patients that he would see with John Walker Smith in London. It was really easy. You had almost 1 or 2 treatments, which was basically a feed. And if that didn't work, you had steroids. And if that didn't work, you had azathioprine. We thought it was easy but the complications were huge. And this is a child typically who would have small bowel Crohn's disease with stenotic disease. The quality of life was poor for these patients. Now, in the last 10 years, it's completely changed. About 5 years ago, this would be the pattern of care, for example, for Crohn's disease. We would opt for enteral nutrition at St. Mark's. Steroids is used widely, but we would prefer enteral nutrition, and you're going to see me talk about that. We would use azathioprine early, but we would not necessarily institute biological therapies early. If you didn't improve on an immunomodulator, you might get more enteral nutrition. We would look at fecal calprotectin, but it was not always the best marker. We might check your growth. We would look for surgery. This was 5 years ago. Things have changed. If you look at ulcerative colitis, we were getting confident with higher doses of mesalazine. We would use immunomodulators early. We would chase the fecal calprotectin, and we would consider infliximab perhaps later, perhaps if you had acute colitis. We would be touching on rectal therapies, but we would not be so desperate to use them. And then we would change biologic therapies. We would change class. But again, it's 5 years old. So what's new? Well, we're going to do what's new. This is basically the most up-to-date guidelines that have just come out of ECHO, and it's easy to access. And I'm going to touch on much of what has been said in this guideline. I will be agreeing and not contradicting anything that's been said. So let's start with this child. This is a typical 14-year-old referred, typical history of inflammatory bowel disease, 3-month history. Most of the colon looks all right, some scattered ulcers. But then when you look into the term ileum, it's deep ulceration, penetrating disease, cobblestoning, mucus, stenotic changes. Our options traditionally would have just been enteral nutrition. Perhaps when considering when would we start biologics, we would want to start it early, but we wouldn't know when. So because Georges is sat here, it would be rude for me not to start with one of his papers. And this was a study looking and comparing the outcomes of children after 12 weeks into treatment to see whether you could predict what their outcome would be at a later stage. And of course, this was driven by the Porto IBD group, which has been the powerhouse behind pediatric gastroenterology. And I'm just going to take two conclusions. The first conclusion was that if you were still unwell at week 12 and you weren't in adequate remission, mainly predicted by CRP, then you are unlikely to be well at 1 year of age, 1 year further down. That's one conclusion. So CRP was identified to be a good predictive marker 3 months into your treatment. If you didn't manage to lower your CRP to almost normal levels, you knew you would be in trouble in 1 year. But the part of the one graph I've picked up from that study is that I wanted to show you that enteral nutrition at induction was still superior to corticosteroids, and the chance of you being at steroid free remission at week 12 was still better for enteral nutrition. There is a trend, even in this observational prospective study, that enteral nutrition is superior to steroids. And you're going to see why I'm going to dwell on that. And I'm allowed to, because both of our chairs today have worked in centers where enteral nutrition is still preferred. Calprotectin was not really a useful marker judged from George's paper. But the Dutch study only published last year has shown you that if you can achieve a target normal calprotectin of under 100 at 12 weeks into treatment, the chance of you requiring further intervention and the chance of you still being in remission at 1 year was favorable. If you you reached a calprotectin of less than 100 at 3 months into treatment, you were quite likely to remain in remission. Less so if you failed to reach your target calprotectin. So this marker at 3 months is either calprotectin or CRP, gives us some information about where you'll be at 1 year. The risk study, which was published about 3 years ago, was the most deeply studied into looking at risk factors for active Crohn's disease and complications. And when you put all of that, as well as the 2 studies before, it is clear that when you see this child's colon or his terminal ileum looking like this at diagnosis, with either extensive panenteric and colonic disease, what you can see here, deep ulceration, stricturing disease, you can imagine that this is already transmural. You can predict that they won't have a good response adequately at 3 months. They probably have growth failure. Then we should be able to personalize their care. So what does personalize mean? And that's what is new in IBD. So I want to dwell on this study. This will be the study we're going to talk about the most as new in IBD. It is the most impressive study published by Lissi de Ruyter's group, and is so impressive because it changes the way we think. The introduction to this study by the authors explains, as we already know, that pediatric Crohn's disease has a more severe phenotype. It still does, it always has. And because damage from Crohn's disease is accumulative over time, if you start Crohn's disease in childhood, you're going to run into complications early. The adult equivalent of this study was published about 15 years ago, suggesting that early use of infliximab, additionally with immunomodulators, probably helped remission. So just look at the way this study was designed. It's very straightforward and very easy to understand. Everybody gets azathioprine, but instead of getting the standard treatment as published in the Growth CD study by George's group, enteronutritional prednisolone, de Ruyter's group had the opportunity to give infliximab at induction, and then either to continue it or to discontinue it. And patients were randomized. This is the most useful slide for you to see. It looks at the outcomes at 10 weeks. One part of the chart looks at infliximab at induction, and the other part looks at enteronutritional steroids. Your chance of clinical remission was substantially greater if you got infliximab. Your chance of endoscopic remission, because these patients were all rescoped at 3 months, was substantially better if you received infliximab. Calprotectin was substantially lower. And remember, we've already just stated that 3 months, your calprotectin value at 3 months helps predict your subsequent course. And again, we spoke about CRP just before. If your CRP is normal compared to abnormal, your chances of being in remission at 1 year were substantially better. And here's that data. Your clinical remission at 1 year was twice, perhaps 3 times more likely if you had infliximab at induction. And when you looked at whose treatment needed changing, look at these changes. If you started infliximab, you had about 25% chance of being on it for the whole year. You hardly needed to change onto adalimumab, and hardly any patients needed steroids. Compared that to the group with severe disease who had enteronutrition and steroids at induction, they needed far more steroids, and many of them needed infliximab. Now, the important take-home message from this study is this was not about mild Crohn's disease. This selected the group of patients that you look at when you take your endoscopy and think, oh my God, that's looking pretty bad. And it suggests that we can predict both clinically and in the context of response at 3 months about who's going to need more aggressive treatment. And this individualized or personalized care means that if you can predict who has more severe disease, you could probably offer infliximab early with a double chance of being in clinical remission compared to conventional therapy. It's a game changer. It suggests that facing someone who has this sort of disease at diagnosis, so they now have bad colonic disease, you've assessed them for perianal disease, they have deep ulceration, they have stricturing disease, it is penetrative, you've determined they have poor response at induction, then actually treating these patients on day 0 or within a week with infliximab appears to be preferable, and it will change their clinical outcome. And then the second issue to consider is if the biological therapy is going to be used now at induction for children with severe disease, should we be giving them monotherapy? And the reason I bring this up is because so many patients get striking benefit by using biologics on day 0 or week 1, that we have many patients that say, well, that's it, doctor. I'm on enteral nutrition. I feel so much better. Why do I still need to take azathioprine? So I take you back to an old study, which is still the game changer now. The more medicines you give, the better you respond. And this was the SONIC study. And in case anyone missed this, it's about 12 years old, but showed that azathioprine for Crohn's disease in adults has a chance of inducing remission in this particular cohort of about 15%. That's half of the response you gave if you got infliximab monotherapy. And it's only a third of the response if you take both. Something happens if you take both biologics and immunomodulators together. And if you think this has complications, that's wrong. We found that this cohort specifically realized that you are less likely to get infections, which is a marker of poor care if you got double therapy. The same may not necessarily be true of methotrexate in adults. And I just want to share this with you, that Brian Fegan's group showed that methotrexate may not be as an effective adjunctive combination therapy. And that's not necessarily what we found in pediatrics. But I just want to raise a question about methotrexate because it is becoming increasingly popular. So because I know that Professor Piadete worked with Anne Griffiths, I bring up this paper. This looked at patients that you will most certainly would have one day looked after. This looks at who was still on infliximab 5 years after it started. And it looks at those people who had azathioprine for a long time or a little bit. And look at this data. The chance of still being on infliximab because it still works, or the chance of being on infliximab because you have not developed antibodies, was 70% if you were on azathioprine, and and a good chance less if you were not on azathioprine. And if you only have azathioprine for 6 months, it's between. The data in this study suggested methotrexate was superior, but the number of patients on methotrexate was very low. So we should ignore this row. But double therapy seems to mean you can rely on infliximab for longer. And when you take a prospective study, which was published into JPGM, this informs us that you don't necessarily need dual therapy forever. Infliximab for 1 year with azathioprine gave you a chance of loss of response of about 4%. But if you only gave it for half the year, it was the same. In fact, you were clinically felt the same. The conclusion from this particular study was perhaps you don't need a whole year. The take-home message is those at high risk, and we haven't defined high risk, but I know that you all understand what that means. There's good reason to start dual therapy early. Yes, still give your induction with enteral nutrition, but perhaps don't wait to fail by 3 months. And because we can use immunomodulators to support biologic therapies, perhaps we don't need such high TGN levels. We can actually manage these patients on lower levels of azathioprine. And that's what we're starting to do with our cohort in the UK. You could stop the immunomodulator, your azathioprine, at 6 or 12 months. And I just want to throw in that there seems to be less grounds for combination therapy in patients with adalimumab. So the first 3 educational outcomes from today is that if you could predict the more severe phenotype, even waiting for 3 months to look at CRP and calprotectin, or using the risk stratification published by other authors about penetrating disease, then perhaps you should start biologics at diagnosis. And perhaps you should also start immunomodulators. But is this the end of enteral nutrition? Well, diet and Crohn's disease, as well as ulcerative colitis, which I haven't discussed yet, are deeply embedded together. So let's just start with our understanding about nutrition and Crohn's, and then it will help put the role of enteral nutrition into question about maintaining remission. This diet is bad for you. Canadian studies have confirmed that your relative risk of developing Crohn's disease if you eat this on the left compared to this, which is the beautiful Portuguese breakfast, then if you have a British breakfast, you have a relative risk of developing Crohn's, which is substantially more. And the OR, for this is about value of 5, it's a substantially greater risk. Our breastfeeding rates in the UK are terrible, and we have bad Crohn's disease. Breastfeeding does indeed protect you. But the problem about all of these studies, looking at bad diet, looking at high fiber diet, looking at breastfeeding, is much of this has a recall bias. The data is not easy to be clear that just by eating these foods, you reduce your chance of Crohn's disease. Modulife, which is the new trick in the box, which is Ariel Levine's group from Israel, are suggesting that you can change the diet for patients once they have a diagnosis of Crohn's disease and change the outcome of their disease. So I'm going to just run through this. These are the adult studies which were published nearly 13 years ago. They were Japanese studies showing that if you had patients taking enteral nutrition versus those who took no enteral nutrition, so this is for the whole year, then your chance of being in remission became less as time went by in the patients who take no enteral nutrition. The adult studies suggested that enteral nutrition given for as much as 12 months on top of normal food impacted on your chance of remission. Actually, what does the pediatric data suggest? Well, this is a summary slide, but it shows, starting with this row here, that enteral nutrition is superior to, so full enteral nutrition, that is just nothing but, for example, modulin for 8 weeks, that chance of inducing remission is far better than having a bit of modulin and a bit of food at induction. PEN, partial enteral nutrition, is not effective at inducing remission. The second line is PEN, partial enteral nutrition as maintenance, may have some benefit, but it's still not proven. And I know it's proven in this study, but in pediatrics, it's still not adequately proven. But let's have no doubt that partial enteral nutrition as maintenance must have no downside. You're giving more calories and you're giving the right type of calories. And we know that if you give the right type of calories, whether it be carbohydrate or the nutrition in protein, it seems to have some impact on Crohn's. And the Modulife diet, scrolling back here, talks about having a diet that's more like this, less like this. So perhaps there is nothing to be lost by taking on Modulife. But just remember that enteral nutrition is not just for maintenance, it's also for perioperative care, and it's also for complications, fistulation. It's used extensively in adult patients who have complex intestinal failure. This works far better than partial enteral nutrition. And finally, I want to share with you that maintenance partial enteral nutrition seems to act effectively as a bridge between therapies. So patients who are failing on infliximab, who may have to bridge onto a different biologics, there appears to be good value in partial enteral nutrition. So if you look at the educational objectives, I want you to see that there is a role for maintenance enteral nutrition in children and adolescents. And I've summarized it on this slide. It's not compelling, but it's certainly impressive. And I want you to think back to George's study that I showed right at the beginning, that enteral nutrition still is superior to steroids. So that's moving away from diagnosis on Crohn's disease. We're going to start moving a little bit. We're going to stay a bit with Crohn's, but we're going to talk a little bit more about ulcerative colitis. In the process of doing so, we're going to talk about infection. And we can't talk infection unless we talk about COVID. The ECHO guidelines was very clear about COVID, and we learned very quickly that we should not be changing the treatment of our patients during COVID. And we have all stuck by this. I have been so impressed with our patients who keep coming to clinics, who keep coming for their immunosuppressants, who keep coming forward for their infusions. The outcome is very clear that we should not reduce medication because of the risk of COVID. We shouldn't change our biologics. We shouldn't change our immunomodulators. We shouldn't change our new JAK inhibitors. And if someone does develop COVID, then we just postpone their biologic, we decrease their steroid, and we often discontinue their immunomodulators because the half-life of these drugs is so long, we can tolerate that change. Of course, we test for COVID before we give patients anesthetics, but we do not delay their endoscopy. One of the best outcomes we've had from the past year is our sedation endoscopy has really come into its own, because then they don't need an anesthetic, they need just a little bit of sedation. And we've been able to continue changes in biologics without any interruption. It's changed the way we offer online consultations, but our COVID experience is a positive experience and not a threat. I want to just share with everybody that when you are called to the ward with a patient who has abdominal pain and diarrhea and raised inflammatory markers, now is not the time just to think about inflammatory bowel disease. And I remind you that there is a rare but multi-system inflammatory condition that looks like Kawasaki. And if you just look at their abdomen and you forget to look at their face, you may indeed miss the fact that they have a more serious respiratory and cardiac condition, which is associated with multi-system inflammatory disease. And as gastroenterologists, we are called to see to these patients, and we should have some knowledge of this condition. So, COVID aside, what do we know about Crohn's disease, biologics, microbiota? Well, let us remind ourselves that when we were just talking about enteral nutrition, we're actually still talking about microbiota. The role and mechanism for enteral nutrition at induction and the role of microbiota in partial enteral nutrition, it is still embedded with each other. When you change someone's nutrition, you change their microbiota. Just by removing one food group, we will change the way that bile acid is metabolized. We may change sulfite metabolisms, which is integral to inflammatory bowel disease. Fecal transplantation has a role in adult inflammatory bowel disease. The pediatric studies failed to actually become established. We had a beautiful study to start in the UK. It never came ahead, mainly because of COVID. There is a role for probiotics in distal disease and pouchitis and ulcerative colitis, but there is little benefit in probiotics in patients with Crohn's disease. And I throw in antibiotics, partly because it's Friday. And I just want to leave you with a little thought about antibiotics. We use this for our patients who are inpatients, but does it work? And this complex algorithm is just to remind me that Ariel Levine published in Gut this year an interesting study taking pediatric patients with mild to moderate Crohn's disease only and randomized them to either have azithromycin, which inherently has anti-inflammatory qualities, or azithromycin versus just metronidazole alone. And he looked at all of these markers: remission, PCDAI, CRP, calprotectin. And look at the blue bars versus the red. Blue is azathioprine and metronidazole, and the red is metronidazole alone. You get a better response with dual therapy. You get a better remission with dual antibiotics. You get normalization of CRP in the same group of patients, but the chance of you needing newer therapies or other therapies at induction is greater if you use metronidazole alone. This comes back to a theme that I've addressed before, that more interventions early interventions, more medicines at induction seem to lead to a better outcome, whether it's biologics, whether it's azathioprine, in fact, whether it's 2 antibiotics versus 1. Azithromycin is an interesting medicine because it has anti-inflammatory qualities. But this is, I'm not suggesting that we use this at induction, but it's an interesting finding that you can use, you can change antimicrobials with antibiotics, and they themselves can affect your chance of remission. So we're nearly there. We've looked at phenotype, biologics, immunosuppressants, maintenance enteral nutrition, a little bit of microbiota and COVID. What's coming next? Well, before we talk about the new biologics, let's just remind ourselves that we're only starting to get good at using the biological therapies we have already. I think most of us have realized that patients with ulcerative colitis, they don't seem to get better on the standard dose of infliximab. Why? Because they almost certainly leak it over the whole length of their colon. And actually, the 5 milligram per kilo is probably an underdose for most children who have widespread disease. And we know this because we can measure their infliximab levels early. We certainly know that adding immunomodulators seem to perpetuate the benefits of infliximab. So that helps us keep with the original drugs. We know that we can measure drug levels, and actually the presence of antibodies alone does no longer seem to be the only reason to stop a biologic therapy. We have many patients who have an antibody to infliximab who we can still persist with the infliximab therapy safely if we either optimize their dose or add in immunomodulators. And this gives us a longer period, a longer life for using that specific biologic therapy. And this has been our saver. I have spoken already about repeating endoscopies. If we can consistently have access to endoscopy, we can often find that children who we think may not be doing well on biologics, when we actually endoscopically assess them, they are doing well. And the value of re-endoscoping patients, perhaps 6 months into treatment or 1 year into treatment, with or without anesthetic, often gives us a longer lifespan with their biologics. What are the new biologics? Well, let's do ulcerative colitis first. So vedolizumab, which is the monoclonal antibody to integrin, which is part of the lymphocyte trafficking, this works. But again, earlier treatment with TNF, using it in patients who don't even, earlier use of vedolizumab in patients who haven't even had exposure to infliximab or adalimumab seems to be beneficial. You get a more substantial remission compared to placebo and a longer remission, and you get less of a response if you've already used a TNF antagonist. Why would you get less response if you've already given them infliximab? Well, they may have more stubborn disease, or it may be that vedolizumab is actually better at targeting ulcerative colitis. And when you compare adalimumab against Vídeo, which was part of the Varsity study, actually Vídeo is a superior product at 1 year. There's something about the monoclonal antibody of vedolizumab which is probably preferable compared to what we were using before. I won't be talking about this specific product because it has no pediatric aspect to it yet, and its response in ulcerative colitis is still unclear. It has a significant risk of infection. But ustekinumab is actually increasingly popular in pediatric practice. This inhibits IL-12 and IL-23. But its role in ulcerative colitis is still questionable. It still has a value, and its clinical response rates are still good at 50% with decent clinical response. But actually in the UK, does not currently have a place in treatment for ulcerative colitis, whilst Vídeo does. For Crohn's disease, the matter is a bit different. I'll start with ustekinumab. It has a very impressive response rate, particularly if you've already failed TNF antagonists. So this is now our go-to drug for patients who are failing TNF. anti-TNF drugs. Vedolizumab, again, if you are TNF naive, you seem to respond better. And the clinical response is up to 50%, so it's comparable with ustekinumab. And it leads to long remission with 8 weekly infusions. It seems to have a similar response to infliximab. And actually, it may be that vedolizumab is behind the curve because it's come in a bit later. It may actually have a superior role in ulcerative colitis. And you do question that if steroids, infliximab, and vedolizumab were all brought onto the market into the 1960s at the same time, it might be that vedolizumab would have won over. Current guidelines, NICE guidelines, guidelines published in Gut show that there's very little between adalimumab and infliximab, and the response rates for Vídeo and Ersto are lower if you wait too long to use them. And if they are lower, you seem to be less likely to get a response. Again, early decisions, this is the theme of today, early decisions seem to lead to more protracted response. And now for the last 5 minutes. If the drugs fail, what else is there? So Crohn's disease used to have a close relationship to surgery. 80% of patients with that bad terminal ileal disease I showed you at the beginning were more likely to undergo surgical resection. In fact, historical data shows before biologics that about 80% of patients with terminal ileal disease would end up with surgery. And this has only been reduced to 50% in the new ages of biologic. It's not disappeared. The surgery is not particularly favored because it had a high relapse rate and a high endoscopic recurrence, and sometimes required recurrent surgery. So it's fallen out of favor. And may I be provocative to my Portuguese friends and suggest that one of the reasons why surgery has fallen out of favor is it's not driven by drug medication. So a lot of money and investment and product placement exists for biologics because they're great, but they're a drug therapy. And surgery fell away behind the curve because there was no one promoting it. Until this study came along, which was the LYRIC study. It's an adult study, it's multi-center, and I bring it up because it reminds us that although we have new toys, there are still lots of good old toys. This is the LYRIC study, and it compared patients who were offered and randomized the laparoscopic ileocecal resection, we'll call that the ICR, or infliximab for the terminal ileal disease. And this would not be at diagnosis, it would have been 1 or 2 years into their treatment path. They took 143 adults, 70 of them were offered infliximab, and 7 of them were randomized to the ileocolonic resection. Out of this group, 6 of them subsequently, within a year, needed infliximab. And out of those offered infliximab, 21 of them had to stop it. In fact, 13 of them needed an operation and 8 of them lost response. This is very typical for pediatrics as well, that actually infliximab's great, but it doesn't last forever. This seems to almost have the advantage. You have the same number of days in hospital. Those in the infliximab group had to stop treatment, and those in the surgical group, some of them needed infliximab. So this looks great, but it's not so great. Because when you then look at Mike Cam's paper, another adult study, but of course it applies in pediatrics, what happens if you wait longer? And this study confirmed, it was a prospective study where you were randomized to just either sit and wait and see what happens at the anastomosis, or you went looking at 6 months, 1 year, 2 years, you kept looking at the anastomosis. And if you saw a relapse, you decided to treat early. And that was the nature of this study, randomizing patients to active treatment after right hemicolectomy. An endoscopic relapse happened frequently, symptomatic relapse happened frequently. Some patients needed an operation, and smoking was very bad for you. That was a clear conclusion. Options for therapy were either metronidazole, metronidazole, and back to the thiopurines or infliximab. And these were the options that were currently offered in a group that you would just watch. And we need to get used to this. This is called the Root-GERD score, and it's a really useful score that we address every time we endoscope these patients. And we come back to that question, because we have access to sedation colonoscopy, we can scope these patients at 6 months and a year, and we can quickly identify whether they actually have more active ulceration at the anastomosis. Why? Because Mike Cam's group showed that if you took an active response and you gave these patients, you screened them early, or you just waited, those patients that you just waited were more likely to have a recurrence, which was bad for them, perhaps needing more surgery or escalation with treatment. If you gave them adalimumab immediately on seeing active disease, you were less likely to have a recurrence, and you are less likely to need thiopurines. Actually, early intervention had a better outcome. The same theme for the whole of this discussion. What's new in IBD is that we don't have to wait now to need our biologics. We can now consider using them early in the course of their disease. So one of the conclusions is that access to sedation colonoscopy helps, gets you to look early. Patients can be discharged, should be discharged on some medicine, and we should be looking early. And finally, for the last 2 or 3 minutes, let's talk cancer. We don't talk cancer because we talk about disease, but let's not fool ourselves. In ulcerative colitis, 1 in 6 deaths from ulcerative colitis are about cancer. And we are dealing with our cohort with patients who have got a lifetime of inflammation. And the age of onset makes a difference. And we need to start screening patients from about 10 years into their history. In fact, the more recent BSG guidelines talks about starting at 6 years. How many of our patients fall into that group? Because the risk of cancer is 1% at 10 years in ulcerative colitis, 3% at 20 years, and 70% at 30 years. So if we diagnose a patient with ulcerative colitis at age 10, think of their risk at the age of 40. We need to talk cancer to our patients. We need to, in what's new in treatment of inflammatory bowel disease, the ability to talk to our patients about cancer risk with thiopurine, cancer risk with combination therapy, cancer risk related to the duration of disease. We need to tell patients that their cancer risk from Crohn's disease is actually greater than that of ulcerative colitis, that it's significant in those patients with primary sclerosing cholangitis. And we talk about this early so that patients invest in early treatment. And we warn them about the type of cancers. The risk is still small. It's 1 in 6,000. The risk from their disease is 100% if we don't treat them. So let's not fool ourselves. These numbers are small. We do tell patients with PSC that we need to watch them closer. We do access the international databases, which are looking at prospective data. But this is my warning to all of us. None of us in this group, unless we are adult doctors, actually have the surveillance skills to look for cancer. We are good diagnosticians, but we are not good cancer screeners. And so for our patients with PSC, they need to be screened by those patients who have skill in surveillance and dysplasia. And that requires training, requires white light, chromoendoscopy, water to wash the mucosa, because the changes can be subtle. Here's our little foot pump. You need to look at every detail of the mucosa, and we don't have that skill. And so already at transition, we get our adult colleagues to look for dysplasia. So I would suggest, in time for our 40 minutes and our bottle of port on a Friday night, we've covered all of our educational objectives. We've concluded that actually we have a responsibility to predict a more severe phenotype, either from the nature of their disease, or their endoscopic appearance, or their CRP, or their calprotectin. We can use biologics even in the first week of disease. We don't have to wait for 12 weeks. We should not be afraid of using combination therapy for 6 months or a year. Enteral nutrition works, and maintenance nutrition hasn't been proven to work yet, but it's going to do no harm and must have a role. COVID, I don't think it has an impact on inflammatory bowel disease. There are new biologics, some of them quite likely to be superior to infliximab and adalimumab. There's still a role for surgery, but we have to predict relapse, and we have a responsibility for cancer surveillance. And I think these are just 8 of the new areas of inflammatory bowel disease in the past few years. I haven't touched on acute colitis because I didn't have time to do it all. There are other areas of inflammatory bowel disease that have really made progress. I refer you to the BSG guidelines, which were published in Gut, many of them by surgeons, many of them by international IBD doctors who have been involved in all of the clinical studies. And I encourage you to read this adult paper because it does indeed reflect much of what's coming to pediatrics, and some of the authors are pediatricians. And if you are interested in still using surgery, I refer you to the ECHO guidelines on therapeutics in Crohn's disease and therapeutic for surgery. So I'm going to stop there. I want to thank you all for spending your Friday night with me, and hopefully stopped a little bit early to allow you to drink your port and rest for the rest of the evening. Thank you very much to you all.
Well, you'd have a wide clap from the audience. I will clap myself. And I really thank you for an excellent and very clear talk. Well, I once had a head of department who made a mistake while he was talking, and I corrected him. And he looked at me and said, well, I was just checking whether you were paying attention. So at the beginning of your talk, you said you were seeing 1 new patient per year.
No,
and I spotted that just to tell, I'm sure you'll see many more than that.
I'm seeing one, yeah, it's one, we've been seeing about 1 to 2 a week. My apologies.
Yeah, everyone understood it. That was
thank you for paying attention.
Well, we have a few questions from the audience. I would start by asking you, you mentioned that when patients on biologics have COVID, you might postpone the biologic treatment for a while. Do you have any standard delay, or does it depend on the severity of the patient or the severity of the COVID infection?
So we hold back on the biologics because it's hard to convince the patient to take an immunosuppressant. We know from databases that children do not run into additional trouble by having biologics and COVID. The half-life of these biologic therapies is so long that to delay infliximab by a week is not important. To delay azathioprine for 2 weeks is not important. So we tend to wait until they are COVID negative, which is only 1 or 2 weeks. But we decided to do this based on the ECHO guidelines because it just seemed unfair to bring them to hospital with COVID to give them infliximab for their inflammatory bowel disease when actually they were now more worried about COVID. I think most of our patients can tolerate a short delay in either commencing or having COVID, having their biologics. So our approach was only to delay by 1 or 2 weeks. But the truth is the number of pediatric patients with proven COVID and inflammatory bowel disease was very small. And of course, there's a clinical trial still taking place in the UK using infliximab for ventilated adults with COVID. So we empirically chose 2 weeks.
Okay, thank you. Well, there's another question talking about infliximab. Which is your highest dose that you use? Do you stick to the 5 to 10 milligrams, or do you guide by the trough levels and then you may go beyond that in occasional cases?
So we make a multidisciplinary decision, sir. I find it very difficult to make the call alone because I worry about drug toxicity. For a new colitic, I would have a new patient with ulcerative colitis, I would have no difficulty giving them 10 milligrams per kilo. I would often give them 5, wait 3 or 4 days and give them another 5. And that would take them to 10 milligrams. And then I would ask advice. We might get trough levels back, Professor Diaz, but they take so long, we don't often have them back in time.
Yeah.
So I would have no difficulty in someone with colonic disease giving them 5 milligrams per kilo and then another dose. And if I really got pushed to giving 10 milligrams at induction. However, I am aware that there are others who are more courageous than me who would give 10, 15, and I'm even aware of Dan Turner's group who've given 20 milligrams per kilo within a week. And I'm sure the Canadians are as well. But we are then so closely embedded with our surgeons. The question is, are you wanting to give more before they have surgery? So my personal limit is 10 milligrams per kilo in one go. I wouldn't be afraid about giving another 5, but I would have the surgeon ready, sir.
Yeah, thank you. You mentioned about Vídeo, but one of the problems that Vídeo has, especially in patients who are already exposed to other treatments, especially in ulcerative colitis. There's one paper mentioning the concomitant association of Vídeo with tacrolimus in severe colitis. And actually, in our hospital, we had a few patients to whom we gave Vídeo, and we added tacro for a while, because Vídeo sometimes takes a little while to be effective. And we managed to, in the end, stop tacro and keep just them on vedolizumab. Do you have any experience or opinion on this sort of association?
I have no personal experience, although I have heard about this. Of course, the problem, Georges, about using Vídeo in an acute colitis is it has such a long start time. It doesn't seem to be as quick in its start as infliximab. So the combining it with tacrolimus would seem to be so sensible. I would, if you have experience in this and it seems to work and you can maintain avoiding complications from dual therapy in patients who may indeed be heading for surgery, there seems good reason to use tacrolimus. It would seem sensible.
Thank you. Another question, which is a late topic, is about combining biologics. Do you have any experience or opinion on that?
I'm too nervous. I'm too nervous, and I don't think I've needed to yet. I think we've managed to always have time to make the right decision, because in Crohn's disease, you can still fall back to enteral nutrition whilst you're waiting to decide what you're going to do. And in ulcerative colitis, you can still fall back on steroids. And so actually, I've not really had to combine in biologics, and I think we should wait for our adult colleagues to drive this first. Mm-hmm. We are always 3 or 4 years behind our adult colleagues, except for nutrition. When it comes to nutrition, we are 2 decades ahead of them. But when it comes to medicine, we need to follow their guide. And many of us are blessed that we work in an adult hospital, so we get it a little bit earlier. But actually, they need to do that before we do. I'm too not brave enough.
Yeah. Okay, fully agree with you. For a while, there was this discussion about top-down or step-up approach. And I think that the pediatric approach is probably a quick step up. And I will ask you if you agree that not all patients might need infliximab from the start, and they respond and they are kept on remission for quite a while without the need for biologics. But apart from those that have severe criteria to start biologics from the beginning, perhaps we should move the step up, but fast, not wait for many months. Do you agree with that?
I do agree with that. I have spoken about, and I dwelled on the study that gave infliximab at induction, but that's only to make people think. By 3 months, though, which is always been your cutoff, whether it's your study looking at CRP or other people's studies looking at calprotectin, we should not be stepping up slowly. I think increasingly we are all feeling confident that when we've seen someone with panenteric disease and bad, for example, bad Crohn's disease in the colon, bad terminal ileitis, we will often decide to give them infliximab before their induction is completed with enteral nutrition. We are more comfortable about that, but I don't call that top down. Top down suggests you're just throwing everything at them. I call that personalizing. So I think that if you have a child who just has some ulceration, you've made the diagnosis, they just have ulceration in the terminal ileum, then they shouldn't have infliximab at diagnosis. But we have at least a third of our patients have disease that when you take the scope out, you think, the poor child. I often say to my team, this child has got had a really bad day. And those patients, we should be starting treatment early and they don't have to earn it anymore. We used to think, George, you must earn your biologics. You must fail immunomodulators. And I think that the studies I've shown you today show that that is not true. It's not top down, it's personalizing care.
Mm-hmm. Thank you. There are two questions on perioperative management, or for how long do you stop infliximab before surgery, and whether you use diet after surgery, or when do you regain treatment with infliximab after surgery?
So I can speak on this because I work in an adult hospital and we have been driving a process called enhanced recovery. Enhanced recovery means that for any operation, we flood you with food. So in pediatrics, we have shown in Crohn's disease, not so much in pediatrics, but in adult studies, that enteral nutrition, exclusive enteral nutrition, EEN, for the weeks running up to surgery decreases your complication rate. So, but we also don't want to have so much disease that you're going to run into a complication. So we make sure that there's about 4 to 8 weeks since the last infliximab, and that you have had loads of enteral nutrition before your operation, and hopefully you'll start your enteral nutrition within a day of your operation. So we will be feeding you EEN right the way up to your surgery and right the way after your surgery. Most patients don't want to have exclusive enteral nutrition, so we might ask them to drink 1 or 2 liters of modulin as well as eating food. And then we would look at the anastomosis early, about 4 to 8 weeks, preferably not within a couple of weeks, although there is lots of data showing you that infliximab is safe even within a couple of weeks of surgery. Our practice is to use EEN because the evidence base is strong that enteral nutrition up to and including the time of surgery decreases your complication rate.
Well, thank you. If you consider the patient that you've seen for the first time this week with Crohn's, would you offer the Crohn's diet or the usual polymeric diet?
I would still offer an full polymeric diet. I'm not yet convinced that there is sufficient data from the Crohn's diet that's perpetuated by Dan Turner and Ariel Levine's group. I think the data is exciting, but the problem I have, and perhaps other people may pass comment on this, is that the patients seem a bit confused. When I start them on their exclusive enteral nutrition, many of them don't need a nasogastric tube. They start it and they're off, and there is no confusion. And when I've started them on a Crohn's diet, which some of them have requested, and they've gone to Modulife, I feel they remain too confused. The message is not clear. And remember, they've got many messages to understand. They've got a new diagnosis. They're now on enteral nutrition. They're getting better. I'm now talking infliximab. I'm talking azathioprine. And when I give them a confusing diet, they seem to just be confused. So actually, I'm not there yet. I'd like other people to convince me the diet works well. I'm going to pass the question back to you, sir. What's your experience about using this diet, a mixed diet at induction?
I have no personal experience of using the Crohn's diet. Somehow it makes sense from a theoretical point of view that once you get the patient under remission, I probably would recommend the traditional polymeric diet to induce remission. But then that might be a way of avoiding the microbiome changes that lead to gut inflammation again. And perhaps there is a future for the Crohn's diet.
Yes.
Probably not from start, but
Maybe.
at some point down the road.
Yeah.
And actually the same group from Israel, they are actively working on the dietary management of ulcerative colitis. Do you have any feelings on that?
First, I'm going to let your co-chair, you were going to answer as well for me.
No, the thing is I've got some experience because I think the gastro paper from 2019, it's too bad we don't have further data on that, but actually kids like it because you have polymeric, a drink for morning and snack in the afternoon, and they have lunch and dinner of chicken with potato and an apples and bananas. So that's what you give them basically. It's much easier. They like it. The chewing and that part. So the message is not a big problem.
Okay.
So it's my personal modification of
some of this may be cultural. Okay. You know, the English, you tell them what to do and they often just do it. But the Europeans may be more, try different things. So but it
works. I mean,
yes.
It works as the polymeric diet. I mean, not a lot of kids, but I've tried in some, and yes, it's kind of the same. You think within 2-3 weeks they start getting so much better.
So, in answer to your question, Professor Diaz, George Diaz, about the about ulcerative colitis, now that is exciting. You see, diets never really had a chance in ulcerative colitis, but when you look at the data surrounding diet and ulcerative colitis, it's still compelling as an etiology. There's something in there. There's something about the way our fats work. There's something about our diet that although we understand Crohn's and diet, this ulcerative colitis still must have a role. That's really exciting because ulcerative colitis is really left for the management for drug therapy. I'm waiting to see what happens for UC. I think that's a great call, but there's one problem. If you modify the diets of patients on ulcerative colitis, you don't get such a good handle on their disease. Patients who stop gluten, milk, roughage, apples, and just eat nothing, they think they're better. And there's a problem, but it's very exciting. And that hopefully will be a future thought that if you have a better speaker in 5 years' time, they'll talk about diet and ulcerative colitis.
I'd like to go back to immunomodulators. A few years ago, Jeff Hymans was giving a talk in Rotterdam, and he just said that we should take azathioprine out of the shelf of the pharmacies. So this is the American approach to azathioprine. I think that in Europe, we are still far more tolerant to the use, and we still rely quite a bit in the use of immunomodulators with biologics. And I would like to have your opinion on this extreme view and whether you think that methotrexate could replace azathioprine entirely.
So, firstly, it's not for me to argue with Jeff Hyams, but I am troubled by this. I'm still a big fan of dual therapy for extensive disease. Whether it's methotrexate or azathioprine may again be cultural. So we're very tolerant of it, and I'm tolerant of the cancer risk because, as I showed you, the disease has a much bigger cancer risk than thiopurines. And every cancer I've seen in the young adults has been disease-related much more often than it has been about drugs. I have a problem with methotrexate, that most patients don't seem to like it. They just, now I know Americans may be more tolerant, but actually it makes them feel a bit sick. The women don't want it because they've read about it. So that's half of them gone. Look, I know that there's a story somewhere about should we be looking at EBV? Should we be giving methotrexate to boys who don't have EBV? And the story is still unclear, and it becomes down to personal practice. So to help answer your question, I share the information with families. It's got my bias, but I share with my families. 80% of patients offered azathioprine tolerate it. I use it. They don't need injections. They don't need folic acid. They respect it. My patients are more likely to be hospitalized from infections because they have inadequately treated disease than because they are on dual therapy. I'm very loyal. But in answer to your question, should it be taken off the shelf? I think if everything had come out at the same time, infliximab, thiopurines, steroids, enteral nutrition, and they all came on the market in 1965, when I was not alive, I think thiopurines would never have got a chance would have never come off the shelf, actually. But we are where we are. We have them. I think they are part of our armory. I think they prolong the use of biologics. I'm very loyal to them.
Okay, thank you very much. I'd like just two comments. I don't have more questions, but I'd like to make two quick comments. One of them is to completely agree with your comment about cancer surveillance. I don't think that pediatricians or pediatric gastroenterologists are skilled enough or have enough experience to do the cancer screening. So we should rely on colleagues, and probably not even all adult gastroenterologists may have the perfect skill to do it. So we should ask for help from experienced colleagues to do this type of surveillance. And the other comment is about surgery. And I would ask you if you agree or if you have a similar experience as a paper from Amit Asa from Israel, where some patients that lost response to biologics, they were operated and then they regained response to infliximab. So surgery may at some point be a way to reduce the inflammatory burden and the TNF burden that could lead to regaining response. Do you have a similar experience or opinion on that?
A very quick answer to that is yes. You use exactly the same words I do. It's inflammatory burden. You decrease the burden of disease. Surgery works for that. It's now in the bin. Okay, we have to acknowledge we've not taken the disease away. But I still refer patients for surgery, and I sometimes tell patients, even at diagnosis, the good news is your disease is just in your terminal ileum. At a later stage, you'd be a perfect candidate for an operation. So they know at the beginning. I think that, as I said, I think the market has changed because the biologics are perfect, but they're not. And I think that surgery has lost its momentum, but it's going to come back. It'll probably be biologics, surgery, and then more biologics, but it will decrease the burden of disease. It decreases the inflammatory burden, yes.
Well, I have no more questions from the audience. I think your bottle of port is anxiously waiting for you.
Thank you.
Again, I really am very grateful for a great talk and very patient discussion. And I just look forward to welcoming you in Portugal later this year.
So I must thank you all for spending your Friday night with me. It's late and I'll let you join your families. Thank you.
It was a well-spent time. Thank you so much.
Thank you. Bye-bye.
Muito obrigado a todos. Boa tarde.